Ready to commence. Item 195. This is our integrated performance dashboard. Deputy Chief Exec, please, over to you.
Thanks, Chairman. So just a couple of things before I hand over to my colleagues. So we just following up on a couple of points we discussed at the last meeting. So there's a meeting on the 19th of March, which will be to undertake the annual review of the integrated performance report matrix. That's a formal process established. The plan is that once we review this, we will bring any suggested amendments or changes through the relevant executive groups and subcommittees for review and sign off. So the board will then see a complete picture of any amendments to the integrated performance report. And I can confirm, particularly in response to questions from the board at our last meeting, that community data metrics are part of this discussion, as are the inclusion of the quality, diversity and inclusion metrics. Just also one other point I wanted to make on the executive summary before we get into the detail, an update to the narrative in respect of the position reported for complaints, which is in the executive summary recorded as an item continuously failing, and that states that the metrics used within the IPR are to be reviewed. Now, I sought further clarity on this from the Director of Governance, who advised that metrics are being reviewed to ensure that improvements are targeted, which reflect not just timeliness of responses, but also the quality of responses. So any proposal to update metrics, again, has to go through a formal process. It will reflect the principles of the Trust Complaint Policy and will be discussed with the Quality Assurance Committee as well. So just to give the board assurance about that, there's a formal control process, as I say, which ensures that changes to metrics are objectively reviewed and transparently communicated and agreed. Okay, so that was it on the executive summary. Chair, shall we go straight into these sections? If so, Deputy Chief Nurse, please.
And we'll take questions at the end of everyone through that.
Thank you. So for quality and safety, patient safety incidents, we've had one patient safety incident, PSII, during December under the national priority category incident resulting in death. We had no never events reported in December 23. However, we have had one never event in January 24, which is in ophthalmology, and there's a PSII underway. From a complaints perspective, some narrative there, no complaints exceeding 6 months at the end of December, which is really good position. And the patient relations team are now focusing on all complaints exceeding 4 months. So that is an improving position. Falls, 99 falls, slips, trips and falls, 2 of those reported in moderate harm. We started to look at particularly around patients' history before they come into hospital and their frailty score, and patients who fell more than once whilst in our care, we're focusing on those also. 32 of the falls were in patients who did not meet the criteria to reside. From a pressure ulcer perspective, the numbers are staying fairly static at 51. We are doing some work around splitting up. We have said this a few times, but we met yesterday to split the category 2 pressure ulcers into, at the moment, we're calling them avoidable and unavoidable, but it's, so if I just refer to the category 4 pressure ulcer, which is, we haven't had a category 4 pressure ulcer in many years, and so it was a bit of a shock. We've had a 3 and a 4 in the same area this month, but actually that patient had had a long lie at home, had been quite a long time in A&E, and then when they got to the ward, they chose to not comply with the care. So when they were asked to move and things, they were reluctant to do that and developed a category 4 pressure ulcer. So that's the sort of detail we're going to try and get into for some of those pressure ulcers, because some of them it's almost impossible to avoid, but we need to make sure we're doing the right thing for those patients. So just to note, and it is mentioned in the brief summary on the slides, that from April 24, based on the national pressure ulcer guidance, the categorisation of pressure ulcer will change. So we'll still have category 2, but unstageable pressure ulcers will become category 3. So we'll have an increase in category 3 pressure ulcers. And any deep tissue injuries, we won't record as pressure damage unless they deteriorate. So there will be a change, and we are working through what that will look like. And it's very timely with the reviewing the IPR matrix. Family and friends test, again, a bit of a frustrating position that we don't seem to be able to increase the number of responses. So we send out quite a lot of questionnaires by text, but we don't receive very many responses back. So we're looking at other ways to increase that patient feedback, and some of that will be face to face. And we are focusing on the areas with lowest rates. Mixed sex accommodation, 25 breaches, all related to delayed transfer from ICU due to lack of capacity. And that's really about decision making and a risk-based decision. And from the infection prevention and control, we have had a reduction in Clostridium difficile cases. We're sort of dipping below the threshold in month. We've shown a reduction in MSSA bloodstream infections over the last 2 months. We're doing a quarterly thematic review of gram-negative bloodstream infections, and there will be a paper to Quality Committee in 2 months, which will be a deeper dive looking at our figures against the national and local context, and any actions required. And I'll hand over to Jane for the meeting.
Thank you. So BT again, similar in that we're not at our target. We have put some CQI support in that's looking at how our nursing staff can support those VT assessments. The areas we were particularly concerned about with the day case surgery rates, and we have actually seen an improvement in that in the last couple of months. Other than that, we follow it through Quality Committee with intermittent deep dive reports, but it is followed every month of performance reviews with the care groups individually. On patient safety alerts, we have a good process around patient safety alerts. They're all come in, and we're up to date with our gap analysis and treatment plans whenever necessary. And mortality continues to do very well. We are below expected targets. We've had no alerts for the last 2 months, and notably fractured neck and femur has not alerted now for over 6 months. So all of those things are very positive. That's it from me.
Chief People Officer, next chair.
Yeah, no real significant changes to highlight from last month's report. The majority of the people metrics are continuing to show improvements. One area that probably is just worth mentioning is around appraisal. So there is a new policy for appraisal that's going to be timetabled for approval in May. That sets out the freedom to spread the appraisal cycle throughout the course of the year, rather than being rigidly kind of stuck to a cascade arrangement. And that is timed as well to enable us to have the system adjustments, to enable us to have the appraisee feedback on the quality of the appraisal experience to be fed back as part of the appraisal process. So that's a key kind of milestone for us to move forward with in terms of hopefully seeing some step change in appraisals.
Thank you.
Chair of Finance. So the report itself sets out levels of risk associated with the Trust's 23-24 financial position. Our latest review of the risk shows we're continuing to deliver on our mitigations, and based on month 10 information, we believe we've mitigated this to around a residual 3 million at this moment in time. We'll obviously continue to work to deliver our forecast right up to the point that our accounts are closed, and this work, of course, is monitored through the Finance and Performance Committee. I'd also just like to remind the board that the revised forecast agreed at the end of November was required to exclude any assessment of costs associated with further industrial action. These costs will be dealt with as discrete items. Has been some communication this week, which we need to work through with our ICB colleagues. I'll advise the Finance and Performance Committee further at its meeting later this month with the values updated for January and February industrial action, income and expenditure implications. Since the information included in the pack was prepared, I can also confirm that the Trust now formally closed to the outstanding gap against the current cost improvement target. This is really very important. It means that we take no deficit associated with our 23-24 cost improvement targets into the new financial year, which is a material factor in reducing financial risk to next year's financial plans. In respect of our cash support requirements, we've now been notified that we will receive cash backed income for 17.8 million of our original 18.3 million planned deficit. We'll receive this in March. This changes both the actual deficit, which will be reported in the financial reports for month 12 and also for the year-end accounts. It also changes the level of cash support that was required by the trust from the level that was notified to the board before Christmas. We'll prepare a detailed paper on this with Finance and Performance Committee in March as well. Chair, Chief Operating Officer.
Thank you. Start with stroke. The most recent validated data, as the board knows, is an A at fondness for SNAP and a B at RLI. We're waiting with bated breath either on Friday or Monday validation of the Q3 data. Unvalidated data was that would be an A score at fondness and an A score at RLI, which would be the first time we've achieved that. So we'll look forward to that if it stands up to the validation through into Friday and Monday. And Q4 to date, with 3 weeks to go, we're at our best ever scores with A's at both sites. So that remains positive. If that is the case, with the validated data Friday or Monday, there's a set of communication and celebration events lined up for staff and with patient engagement to signify that. For diagnostics, continue 12 consecutive data points ahead of the target. Cancer's a positive story. So the 3 key targets: sustained achievement of the 28-day target, the 31-day target and common cause variation, and achieving in month, and 62 days. These are December data. You'll notice on page 223 that the March 23 target is 70% across our ICB. And I'm pleased to say that in February we're at 73% and expect to sustain that into March. So we'll achieve that local ICB target for 62 days. So 28, 31, 62, always with room for improvement, but making good progress. Access to elective care very much in the business end of the year, with fewer than 15 working days left. We remain on trajectory. We're now down to a small number of named patients who the operational teams out there are very closely engaging with around their procedures or appointments. But we remain on trajectory at this point for 65 weeks. We're in excess of the 109% elective recovery fund target, which is good for patients. It means we've treated more patients, and it's also positive for the trust income. One thing to alert to the board is on page 230 of the pack. You'll see the increased number of patients past their indicative review date. That's largely a symptom of the industrial action. So you'll note in the industrial action we prioritise in order cancer patients, long waiting patients and new patients, and therefore patients past their indicative review date are those that are the patients who are postponed during industrial action. We've got a recovery plan for that. Not every trust records patients past IRD, but it's worth noting that those data are in the pack. And also in the pack are our patient-initiated follow-up rates. So we're currently at 11%, which is the best across our patch and indeed amongst the best in England. But we have got a further stretch goal to get that up to between 12 and 13% in the outpatient transformation programme. So some good work there, but some stretch goals in the programme. And then finally, for urgent care, Aaron's mentioned the significant. So these are December data in the pack, where you see us at 75% against a 76% target, and in common cause variation. As Aaron said, we have seen, as you'd expect, the growing pressure in January and February. We did declare a period of Opal 4 escalation in late February. That lasted for around 72 hours. And we were concerned at that point around the environment that we were operating in. We've come out of that, but still with significant pressure. Ambulance handover within 30 minutes at 75% short of the national 80% stretch target. No change in not waiting criteria to reside. That's around kind of 18% or so. And since last board, we're now in and out of the winter plan. So we stood up the winter plan as described on the 2nd of January and came out of it in the last week in February on time. And we'll keep that capacity de-escalated. Nothing else to add, Chair. Happy to take questions.
Thank you.
That's everything, Chair. Thank you.
Okay, thank you. I'll open it up just before I take questions. I know Chris, you and the team will do this, but when the new changes to the definitions of pressure ulcers 2/3 and the deep tissue change, when that change comes in, it will be marked in the report so that we don't spuddle or anything like that.
Absolutely.
That was Chief Exec.
Thanks, Chair. Just one reflection and then an update for the board. So I'll give the update first. So colleagues may or may not be aware of the letter we formally received on Friday in relation to urgent care performance. It's had much heralded kind of airtime at social media and national press, which would ask to return to the national team our assurance that we will achieve the 76% NE target as at the end of March. We've responded positively to that. That is our plan. That's what we've got in our delivery focus. That's what Scott, Jane, Tabitha, the Trembrets and the teams are working towards. That is not because we were asked to sign a letter. That's because that what is our plan that we would set out to achieve says, and teams are delivering best endeavours to put that in. So just to draw that to a close, Chair, with that audit loop of the request and the response. It's a reflection from me with, I guess, something for us to, as a board, to consider when we talk about next year's plan, which we will do over the coming weeks. We've got further evidence of data now in our integrated performance report that's been triangulated throughout today around that tenacity and that sustainable improvement and the delivery of the key improvement trajectories which we've signed up to. And you've seen them play out either in the stroke data that Scott's updated or 100% recurrent CIP through the transformation approach we've taken to financial sustainability, or some of the work we've done on elective recovery or the staff survey, early indications on trajectories of improvement. And yet we still have examples at board, Chair, where we've seen some of the experience in maternity is not where we want it to be. Some of our fundamentals of care on the wards are still not where we want it to be. And there's still ongoing discussions with colleagues about how it feels to work in Morecambe Bay and promoting that better sense of belonging and connection to our organisation. So whilst we've got the IPR as a data source, I would like us to explore as a board just where we're getting more curious around the experiential side of delivery, whether it's patients or colleagues, or where we know we've got perennial areas of potential underperformance that get masked in the larger scale delivery programmes. How we now get into that next level below of, single degrees of improvement that will push us on even further as an organisation. So I'm not proposing a change to the IPR or the way we use it, just for us to consider as a board how we're setting up through the assurance committees and others with that bit more curiosity in some of the more experiential side and some of the other areas of improvement. Check. It's a reflection on.
Good point. Yeah, thank you. Sarah and Jalaban.
Thank you. So a couple of points just on the quality IPR. Couple of points, just sort of a bit of assurance. We looked at pressure ulcers and I just included in the 3A report. We've also asked that the safe staffing report flags more visibly when we've got a pressure ulcer stage 3 or 4 as that pressure ulcers we wouldn't want to see, just so that that's more visible to us. Just to follow up on the VTE as well, we discussed that at committee. Those actions are captured in the report, but the key thing for us was the trajectory for improvement is expected to be around June. So that's something that the committee will be monitoring through the update report and obviously through the IPR. My question then relates to the Never events. So we've just reported a Never event for January. So we've had 7 Never events over 13 months. Before that, we had no Never events over 17 months. And so my question is, although we've been assured that there isn't a direct connection between the individual Never events, are we assured that there aren't any underlying systemic issues that may be driving them? And so I'm looking for some assurance on that, and I think probably a bit more of a deeper dive so we can be assured about the actions we're taking.
Yeah. Happy, James?
Let me take that because Tabitha's not here. So Tabitha, Richard and I, we have been part of a deep dive, but across the ICB, we've seen an increase in never events across the country actually, and across the ICB. And so we have done a deep dive of them, obviously a bigger number of events across the region to look at those themes. Richard, Tabitha and I went to a meeting about 3 weeks ago, which was about how do we look at this as learning, etc., and what are we going to do to join all of these bits up. We're still waiting for the report, and I know Richard has asked that, and that was going to bring it either to Quality Committee or wherever it needs to go. The underlying themes that were picked out were things around theatre distractions, let's say, around staffing levels, have we always got the right place, staff in the right place around those things, rather than individuals, which would be right within every event. So we will look at those themes, and there is planned that the governance teams, Chief Nurse and the CMOs will be looking at that as a system.
Thank you.
It'll come to Quality Committee. Go to Quality Committee.
Yeah, that's where I presume it would go. I don't think we'd know that, but yeah.
Yeah, no, that would be great. Thank you.
It supports what the Chief Exec said in this statement.
Yeah, thank you. I have a finance question as well, if I'm allowed to ask. Is that okay? So thanks for the update, Chris. I'm just mindful that in early April last year, we were asked by the ICB to make some adjustments to our end of year position, which meant we had to reopen the accounts, and that meant that the external auditor had to provide a slightly different opinion as a consequence of us opening the accounts or reopening them. So just looking for some assurance around the process that we have in place with the ICB to hopefully avoid that happening again.
I have no indication at all that that would happen again. I can't be definitive to say something doesn't come across the line, but all I can say is that the entire focus of the system is on delivering the number it's committed to, and has committed to up the line. So should that change, I would do exactly as I did last year, brief the Finance Committee and Audit Committee Chair immediately.
Okay, thank you.
So the update is nothing's coming through the system to indicate that.
Yeah.
Charlie Barney, please.
Yes, thank you, Chair. So my first question is around family and friends responses, which is a challenge, and I'm glad you are using different techniques to try and get some responses. My question is around the responses themselves. What are we learning from it? Because we're just talking about the numbers per se, but what is the message that we're getting from our patient and our carers? And the second question is around our finances in terms of CIP target or cost improvement targets, Chris, in terms of meeting that particular target. Is it on recurrent, or was still on around 80%? I think in the document it was somewhere around 79%.
Should I take that one?
Finance first, then. Yeah.
No, we're absolutely clear. Our recurrent, the value of the recurrent CIPs that we now have properly logged in our system is 31 million, which is slightly in excess of the full year target. So we take forward no shortfall into the next year's financial plan. Thank you.
But if you just add to that as well, Chris, the next year plan looks quite healthy as well, doesn't it? The CIP from.
So the preparations for that very methodical. You understand the process that we follow, incrementally increasing as we head to 31st of March approval. Obviously, there have been delays in the financial planning timetable. We're waiting to have final guidance, but yeah, absolutely. We've got a robust system. We demonstrated that this year. We're applying further enhancements to next year.
Wait till end of year and the consolidated accounts for that as well. They'll go through finance.
Yes, Chair.
I don't want to forget the first part of your question.
Yeah, so family and friends test, we rely mainly on text messaging. So we ask 5 questions by text, and the respondents come back with They don't just talk about their stay on ward 34 or their stay, they talk about long waiting times. So that's one of the main things that come through, and from ED again around long waits in ED. Other than that, there aren't any specific themes. Care groups are expected to report that through their performance and accountability down at care group level around what are their themes and what are they, what actions are they taking to improve that. When we bring it in-house, we'll have a much better approach. So one of the things we're trying to do is to stop the contract with the external contractor, bring it in-house, and then we'll have much more control over how we ask that question. The original FFT was face-to-face, and I think we should return to as much of that as possible so that we can talk to patients while they're in their hospital.
Because I think it would be useful for us to have an understanding of what our patients are saying about the services they're receiving.
I mean, if you want, it goes to patient experience group. We could ask for an overall report around the main themes, if that would be useful.
Yeah. Thank you, Jonathan. I'll go Karen, then Alison. Karen?
Oh, thank you. This is a specific question around stroke, and it's fantastic to see the scoring around SNAP, but there clearly is a fragility around speech and language therapy, and I know this was highlighted at the last board. I'm just wondering about, can we be assured that we're using all of the opportunities to really be proactive about recruiting, thinking that, University of Central Lancashire run a pre-registration master's programme in speech and language therapy. Are we exploring all of those proactive approaches and potentially incentivised recruitment? Because what we're seeing here is an enduring fragility in that programme, despite the brilliant achievement overall.
Ali?
I can't answer the specific, Karen. I can take it away and come back with a response for you then.
Okay, thank you.
And just to contextualise it, Karen, there is a national shortage of speech and language theories, and vacancies across England are being had to fill. So.
Yeah. No, I totally understand that. It's just really assurance about whether we're just leaving no stone unturned on it.
Thank you. Ali?
Thank you. Mine's around the DNA performance. I did not attend, and it says, there will need to be a step change. So we need a step change. We're at 8% rather than 4%, which is our target. Not completely assured by the statement that we have the lowest DNA rate in the ICB. Still leave it a huge amount of confidence. But if we look at some of the, and I know it says that, one of the key transformations is around children and young people. But if the top 5, 6, you get 6 specialities which have much bigger numbers before you get to paediatrics. But then also there are some low numbers like general surgery or even breast surgery where it's small numbers, and hepatology where I can't say that, so I was trying to avoid it, but I need to say it. It's only 38 people. It says only 38, but it's over 20% of the outpatient appointments that were DNA'd. So there's definitely some targeted stuff we need to do, because if we're running at over 10%, which we are in quite a lot of specialities, that's a lot of waste, but it's a lot of missed opportunity, isn't it, for the flow and for getting people discharged and for preventing bigger issues happening down the line if we can get people sorted.
Scott?
Yeah, so I think the DNA rates are lowest in the ICB is just a fact, it's just a number. So that's a fact.
No, it's great that we're the best in the ICB, but if as an ICB we're not actually performing really well, then is it a good benchmark?
Yeah, no, absolutely. I think so DNAs are a part of the transformation programme, and you're right, rather than a kind of diffuse programme, which probably doesn't land, there are some targeted areas. And so one of the benefits realisations of the outpatient transformation programme is to choose, actually, it's five, interesting, to choose the 5 areas where the biggest bang for buck will be. And there's all within some of the specialties you pull out. There'll be demographic reasons, particularly in hepatology, where DNAs there's a higher propensity to DNAs. But yeah, so I think the against the national average of around 6% with 8, we need to improve in focused areas, and those focuses will come through the outpatient transformation programme.
Jane, do you want to comment?
So I think, yeah, just talk on that, I think we do need to remember that there will always be, if we look at the bad people function, there'll always be areas that are much higher DNA rates. Breast surgery will be low because all patients are referred on a 2-week wait and are seen very quickly, so they've not forgotten about the referral or been somewhere else. And yeah, hepatology I was going to pick out because the patient population is has more challenges, I would say, things like that. So I think we need to remember those things. And again, like I say, small numbers. We need to change people's behaviours about cancelling appointments rather than not DNA in, which is a big thing. And I think we see that more in the things like physiotherapy, dietetics, etc. Those sort of chronic, ongoing things. I think it's much easier that people don't get in the habit of cancelling those and just don't turn up. So yeah, it'll come through the outpatient transformation, but we will always have peaks and troughs of different specialties and areas that have higher than expected.
I just wonder whether it's worth doing a review and a quality impact assessment on the DNA rates, just to see if there's any particular pockets of the population who are maybe struggling, or maybe things aren't accessible at the times that suit them and so on. I just wonder whether there's something that we could do there from a protected characteristic perspective, and particularly deprivation profiles as well.
Sarah?
Yeah, thank you. 2 things. So I guess I was just asking myself if we're talking about the outpatient transformation programme as being part of the answer, what's the kind of reporting or assurance route for the outpatient transformation programme? So where do we see that? Was my first question.
So it's a fundamental component of the TIM. Now the assurance route is that there is a route through the Trusts Committee infrastructure that is designed for assurance, but the oversight of the programme is through the Transformation Improvement Board. We are bringing a clear articulation of that through. Actually, at the moment, we signed it off at the Executive Directors Group yesterday, so we can share that. Actually, it'll come through the process, which is overseen by Audit Committee anyway. But we can articulate that for
So
you.
it's the Transformation Improvement Board, Audit Committee Board.
Is that the answer?
Yeah.
Yeah, okay, thank you. And then just building out from Ali's point, actually, and trying to solve these problems, so they're very complex, but actually hearing from the community team this morning, the therapists who were out in the community, district nurses, is there any potential opportunity for joining up to support that some of those patients and people in the community to access the services? It's a question I don't expect an answer at this point.
Take that as an observation. Quick one for me, for you, Scott. Criteria to reside now bubbles around 18 down to 13%. Don't think we've gone below 13%. These are real, all this data represents real people. So these are real individuals who really don't need to be here. My question is, are we in danger of normalising this, that we begin to accept our bed occupancy 18% is criteria to reside, or is there any light anywhere that can say, actually, we're doing something and this will change by May or June?
Yeah, I think by our outputs, you would have to say that we have normalised it, haven't we? It's been the same for over a year. So in outputs we have as a system, in intent and desire and passion to not have it as a thing, absolutely. We're seeking not to normalise it. I think I would say in the last 1 to 2 months, there is a bit of of a step change in the pieces of work that point towards NMC2R. For example, things that the system has done in the last quarter that it wasn't doing in previous quarters, like a joint piece of work with the local government association and discharge pathways. We've done some quite eloquent work there, and some real tangible actions and potential service changes coming from that. The ICB, with its executive leadership, sponsoring a detailed piece of work, including the funding model and the clinical and operational model for intermediate care and discharge to assess. That's new and different, and it features regularly by escalation, and then some of those pieces of work result from that at the improvement and assurance groups through the ICB. So I could point to different conversations, I could point to some new processes and pieces of work, and I could point to some very specific, and as the colleagues earlier that gave the patient story referenced some things that we're getting into. Could I reference anything at scale at this point that's going to eat into that? No, I couldn't. So I think that suggests it's not normalised in terms of desire to address it, but you would have to say by our outputs it is now a normalised part of our infrastructure.
Anything the board can do to help in any way?
I think the obvious one, the continual challenge to not normalising it, the continual exposure to a board, public and otherwise, and through subcommittees. I think in the spheres of influence at the various system fora that colleagues are in, then absolutely. Otherwise, nothing that comes to my mind.
Okay. Colleagues, we're asked to, oh, sorry.
So just for the minutes, Mike, so quite a few discussion points on the DNA rates. My proposal would be that we'll kind of summarise those points and we'll refer that back through to the Patient Transformation Programme Board to inform the work of that and the Transformation Improvement Board as an action from that discussion.
Yeah. Colleagues happy to support that? I'll go Chris, then Karen.
Chair, I'll just correct. Can I just correct my answer to Sarah's question about TIB oversight? Transformation Improvement Board reports directly to the board. The process, the effective operation of our processes is overseen by Audit Committee. So the board will receive the report directly from Transformation Improvement Board for those workshops.
So that's where we look for sure.
Yes.
Okay, thank you.
Thank you for the clarity. Aaron?
Oh, thank you. And this is just to the not meeting criteria to reside, and those people that are stranded in our care, in essence. And just reflecting back to the patient story we heard this morning, we heard about a number of significant points, but including the ability of the family to support. And I'm wondering, have we got, or would there be value in a population health lens into our not meeting criteria to reside patients, so that we really understand the potential and capability and challenges their families have to support their discharge? Is that a lens that we might find helpful?
I'll take that as an observation, Karen.
Yeah.
Text to take away and ponder on, because it's a good point. Thank you.
Thank you.
Just check round, colleagues. No. Are you happy then to note for assurance the integrated performance report for December 23, which is what we received, and acknowledge the actions being taken to improve the performance against the areas flagged and discussed? Chris, thank you. Exec colleagues, thank you for that. Then we'll move on then to 1952, with the minutes of the 3A reports from the various assurance committees. Min, shall we start with finance and performance? Anything that you wish to escalate or bring to the attention of the board, please?
So yeah, there's just a few points that I'd like to mention. So we talked about the requirement to keep focused on the financial position, which has been touched on. So there's been some really good efforts from the colleagues and the teams on that. So that was something that's kept in focus. Second point relates to the ICB block contract situation. That's been discussed in a couple of FNP meetings now and has been put down as an alert because there's just slow progress around that. Not as a result of lack of desire from any colleagues internally, but just the time in terms of the political situation as it unfolds. So that's something that's kept in focus. And then the third point is regarding the electronic patient system, which was discussed in the last board with delays. So that's now coming in our subcommittee meeting that we're going to look at monthly as well. So we're just keeping all eyes on that in terms of what it means, both from a financial perspective as well, renegotiation of contracts and end users as well. And then the other thing that I'd like to mention that wasn't really noted in our last subcommittee meeting, but that is a meeting priorities reside that has featured, and it is regularly featured and discussed and mentioned. So it ties back to your question of, what more can we do on that? Yeah.
Thank you. Any questions on finance? Happy to accept the reports. Okay, thank you. And then quality, Sarah, please.
Thank you. Actually, just to follow on from the point around not meeting criteria to reside, quality committee is receiving a report on a bit more of a deep dive around those patients and any themes. So that's coming to quality committee in March. So just to build on that. So not about the performance, but actually about the patient experience. In terms of the quality committee, most of the points have been covered already elsewhere on the agenda. So the only point I really wanted to draw attention to was that we considered the risks on the risk register that relate to quality committee, and we identified some that were either estates related where we weren't satisfied in terms of what the timeline is telling us and what the outcome of that timeline might be. So we've asked for a bit more feedback on that. And the other was that there were a few risks that would still be out of tolerance for quality and safety when they reach their target score. So we've asked for the risk management group to have a look at that in some more detail. So those are that's the point probably that I just wanted to draw through to board from quality committee.
Any questions related to the quality committee? Happy to accept the 2 minutes. Yeah, thank you. Thanks, Amin. Thanks, Sarah. Okay, colleagues, then we'll move on to item 196, provider collaboration update. Chief Exec, please.
Thank you, Chair. So this is the regular monthly report that we distilled from the kind of agendas and the minutes from the Provider Collaborative Board. Some broad areas of update contained in the document, in particular the 1LSC progress that we're leading on in the system. Ali's our exec lead. We've got a session later on with the board today to walk through that in a bit of detail, so I won't cover that on here. We've also got the emerging programme of work around the clinical configuration programme, looking at fragile services, some of the clinical networks we have, and then a broader strategic piece due in Q1, Chair, about how might we configure clinical services across the acute and community providers in the future to best effect. Colleagues are engaged in that process, and we're working with a supplier that the ICB have commissioned to progress that work. It will come to the board in due course. The work of the pathology board and the pathology business case progress continues. I think we're now looking at an April or May draft to come through to have a look at the business case as it's developing. Very clearly looking at a proposal initially around a preferred site for the capital investment, and the clinical model is also really important. For clarity here, we are engaged with and challenging the system to be clear on things like quality impact assessment, equality impact assessment, and the financial kind of tests being passed for a business case. And I know the ICBC leadership team are going to be supporting that programme of work also, Chair. Final point for me is we've been asking the ICB for clarity of commissioning intentions. We received yesterday a draft that's going to go to their board in March. There is a lot of work that's gone into that proposal. It's not yet at the level of detail that we needed to inform contracts or service delivery change, but I've asked for a session across providers, including ourselves, with the ICB to refine that document. Again, once it's clear as to the impact on our plans, we'll bring that through the board in due course. But the rest of it's for information, Chair.
Thank you. Any points to the Chief Exec? No, happy to accept the paper. It's an update and we're to note it. Yeah, thank you. Then items 197, you've got the attendance monitoring register. You have the schedule of business. I'll just check with the company secretary. No urgent business being brought to our attention.
Nothing that I've been alerted to, Mike.
We've got the date and time of the next venue, so I'll just last check down with the public board. Feel we've covered everything this morning.
Yeah, not on that point. Is it possible to start the private board at 12, not 12:15? I know we're under a bit of pressure this afternoon with alternative things and whether we could start that a little earlier.
I'll come to that in a second. Okay, so I will now close this meeting at 11:17. So the meeting is now closed. So come back to the chief exec's thing. That means you've either got an hour for lunch or 3/4 of an hour. Need to come back.